Grapes are a sugar bomb. Glucose spikes are dangerous. And orange juice is basically the same as soda. I see claims like this every single day on social media, and your patients are seeing them too. And honestly, it's confusing. It's making people afraid of food, hyper-focused on numbers, and unsure of what actually matters when it comes to their health. So in today's episode, we're tackling one of the most frustrating areas in clinical practice right now: insulin resistance and diabetes management in the age of social media. Welcome back to the Exam Room Nutrition Podcast. I'm your host, Colleen Sloan. I'm a PA and dietitian, and today I'm joined by Emily Stevens, an endocrinology PA who specializes in diabetes and metabolic health. With over 40 million Americans living with diabetes and more than 115 million adults having prediabetes, talking about prevention and management affects almost every patient in your exam room, regardless of what field you work in. So in today's episode, we break down what a normal glucose response after a meal really looks like and why spikes aren't the enemy, how to explain insulin resistance in a way a patient will actually understand, what the science says about natural remedies like berberine and magnesium, and some simple practical strategies that really improve glycemic control. So if you've ever felt stuck trying to answer your patient's questions about blood sugar, this episode is going to make your job a whole lot easier. So get comfy or drive safe and enjoy my conversation with Emily. Emily, I am so excited to have this conversation with you. Thank you so much for the gift of your time. Welcome to the podcast.
Thank you. I'm excited to be here.
So when we were chatting offline, getting prepped for this interview, we were going between two topics, and I'm really excited that we chose the topic of insulin resistance and diabetes management, but we were really close to choosing the topic of twin nutrition. So let everybody know about kind of a little peek into your home life and your other side of your world outside of clinic.
Yeah, my twins just turned 2. So it's a wild time. We have big feelings right now, and we're developing even more picky eating habits, which is challenging me every day. But yeah, one of my favorite things is like fixing healthy toddler meals. I love that. I love trying to figure out, how to make their palates more diverse than even what mine and my husband's might be too.
All right. So if you want to have Emily come back on and we can talk all things twin nutrition, let me know. Just send me a message on Instagram at Exam Room Nutrition, and we can do a different podcast unpacking all things twinsies. But Emily, let's really get into the topic of today. And that is kind of all about insulin resistance and diabetes management. And this is a really hot topic. There's a lot of influencers online that share all kinds of wild information. And I think it's really important to first kind of back up and have a solid understanding of what a normal glucose response after a meal actually looks like. And this is important for clinicians to really explain what normal is to their patients. So can you walk us through that?
Yeah. So, everyone's blood sugar is going to go up with a meal. It doesn't matter if you have diabetes or not. Now, like the ADA, American Diabetes Association, has certain guidelines as far as the numbers that it should max out at and then come back down. But overall, with a person with diabetes, I am looking at their 2-hour postprandial blood sugar. Did that blood sugar come back down less than 180 within 2 hours? And if not, why and what do we need to do about it? But like people without diabetes should peak out around 140 or less and come back down under that number within 2 hours.
So I'm sure you've heard of her, the glucose goddess on Instagram. I can't stand a lot of the content that she shares. And so a terminology now that a lot of people are hearing and they freak out about is a glucose spike. So is this something that our patients need to worry about?
So I honestly am not familiar with that person. I try to tune out a lot of it because it makes me scream sometimes. But I do know that people are all like balancing everything and all of this, and that like blood sugar fluctuates. That's what it does. Like if you check my blood sugar right now, it may be 78. And if you check it in 10 minutes, it may be, 85, 90. I don't know. Maybe I ate something and it went up even more than that. So it fluctuates all day long. It's kind of like your heart rate is what I compare it to, because a lot of people are like, well, I checked my blood sugar 5 minutes ago and it was this, and now it's gone up even more, and I haven't even eaten anything. But there's so much more that affects your blood sugar than just eating, too. But no, blood sugar spikes are a normal part of life. And I think we're going to talk more later about, how to prevent it from spiking super high and get more of the I describe it as like rolling hills to my patients a lot versus having the mountaintops.
I love that. Yeah, we're definitely gonna get into management, but I just had to mention that off the top because a lot of patients are coming in like, I feel like I have to have just a flat line of my glucose all the time. And it's important to remind them that no, this is not true. So let's talk about the individual who already maybe has diabetes or prediabetes. And how do you explain insulin resistance to that patient?
Our bodies, as long as you don't have type 1 diabetes, your body's still producing insulin. And with insulin resistance, your body's having to produce more insulin to keep your blood sugar in normal range. So your body is still producing it, but your cells are not as sensitive to it, which is why you need more.
So let's talk a little bit about diet because this is also a really hot topic. And there's all kinds of diets on the internet nowadays, but three specifically do stick out: low carb, ketogenic diet, and intermittent fasting. And so I love to hear your thoughts on what does the evidence say about like specific dietary patterns and A1C reduction. Is there one that is outperforming others, or is there one that you suggest your patients follow?
So this is a loaded question. There's research on each one of these things. And I would say the most common question that I get is the keto diet. Everyone sees, like, oh, my aunt dropped 70 pounds on the keto diet. And my first question to that is she still 70 pounds lighter? Is she still following that diet? It is so restrictive. So I don't recommend any special diets. I recommend overall well-balanced diet and following like the diabetes my plate. So we'll start with like intermittent fasting. There's been several studies on one of the studies that I looked at, they did it 3 days a week for 12 weeks. And with that, it's also nuanced because if the patient's on insulin, so if they have diabetes and they're on insulin, this is a whole new world. They've got to reduce those insulin requirements during that time to prevent hypoglycemia. So it's really difficult for me to like give a one size fits all kind of diet, but it has been shown to be helpful. It's not one that I recommend to my patients often. If they want to follow that, I will support them in that and give them modifications for that. But I don't recommend like specifically intermittent fasting. Low carb can be interpreted a few different ways too, because in general, the average American eats a lot more carbs than what is recommended. So if you're eating lower carb than you previously ate, you could just be eating a more balanced diet. But in general, ADA recommended like 45 to 60 grams of carbs, depending on male, female, body composition, all that. Now, I was actually going through the ADA standards of care recently for 2026, and they said, it's an individualized approach based on each person's body composition, activity level, because my recommendations for your carb levels or your carb intake is going to be much different for an athlete versus a, elderly person. And both of those people can have type 2 diabetes, which I think is a big misconception. And sometimes just genetics and of no fault of your own. So that's my little soapbox on that. I kind of got off topic there.
No, I love that. And I have a love-hate relationship when guidelines are like, oh, an individualized approach. When it's like, yes, I absolutely agree. Nutrition is nuanced and we do need to take that approach. However, sometimes the guardrail of numbers can be helpful. And I want to linger here a little bit on the low carbohydrate diet because correct me if I'm wrong, they're technically it's a little subjective, that terminology, right? Because low carb for you might be very different based on low carb for me. So is there a quote like true low carbohydrate diet?
So the 45 grams per meal for females and 60 grams per meal for males is kind of the base that we come back to. And I think that would be like if you're in primary care and you're just trying to get someone started, I think that would be a helpful guideline for them. But I don't necessarily think that that needs to be the end all be all. They need to definitely work with a dietitian for sure. In general, I like to show them, we have like printouts of my plate and the diabetes plate. So you want half of that plate to be non-starchy vegetables, so not corn and potatoes, which I'm in the South, so that's what we eat here.
We love it. Yeah.
Yeah, potatoes are in every meal. And then a fourth of that being lean protein, and then the other fourth of the plate being complex carbs. So that could be fruits, that could also be whole grains, which we recommend, and they're not evil. We like whole grains; they have fiber. We need those things too for a balanced diet. So, yeah, I think it's difficult to give exact numbers, but to get them started, definitely work on lowering your carb and changing that carb to a more complex carb like whole grains, fruits, vegetables instead of concentrated sweets.
I totally agree with you. One of my favorite places to start is with finding out what the patient is drinking. I find we can really help their diet and have some great outcomes by just getting them to transition over to water. And in my case with kids, plain milk rather than juice. For adults, sweetened tea, lemonade, Starbucks Frappuccinos, those have
Yeah.
like 60 grams of sugar in it. So I love starting with beverages to really help them at least start to decrease their carb intake. Now, I'm such a huge fan of the plate method. I loved my plate, so I'm very sad our guidelines don't follow that anymore.
Yeah.
But I love the diabetes plate as well. I think it's a fantastic visual. It's really helpful because I think unless you're a dietitian and you're really spending an hour giving education on grams, if I were to tell my dad, who has type 2 diabetes, hey, dad, you need to consume 60 grams of carbohydrate at breakfast, lunch, and dinner, he has no idea what 60 grams actually looks like for a piece of food. So if you were to give, grams, now type 2, obviously type 1's different, but if you were to give gram amount, do you have like a handout that you provide of like a banana is 15 grams and half a potato is this many? Do you do that kind of education or do you really stick with the diabetes plate?
Yeah, no, we have a handout that also like it's kind of a quick guide to carb counting, which and we do an individualized approach with some people with type 2 diabetes too that are interested in going on pumps or that just want to fine tune their insulin doses. But yeah, even people that are not on insulin, I will give them like, and a slice of bread is 15 grams of carbs, like so that they can get a general idea like, holy cow, that meal had a lot of carbs in it. That's why my blood sugar was so bad.
Yeah. I agree with you, and I really like doing that as education and information for them as a great way to be like, all right, let's do nothing, but why don't you find out how many carbs you're actually eating in a day, right? Giving them kind of homework and an assignment to see like, oh, wow, I'm actually consuming like 600, 700 grams of carbohydrates, and this is way too much for me or, whatever. And then you can really work on it, meal by meal, depending on the patient.
Yeah, and a lot of people, like, even in, like, if you do a 24-hour dietary recall, they're not including their drinks. And like you said, drinks are a big deal, and that is, like, my biggest thing that I harp on all day, I talk about all day is, like, what you're drinking matters, and, of course, I want you drinking water, and that is my sole beverage that I recommend, but if you're drinking, I mean, sodas, juices, teas, like sweet tea, Starbucks, all the things, that's so many carbs, empty calories, grams of sugar that you don't need, and you have no idea how that's really affecting your blood sugar till you take a look or you stop it.
Yeah, I love that too. It's a soapbox I will die on. Okay, let's talk about another one of my favorite tactics, and dietitians also use this on the daily, and that is pairing protein with carbohydrates. So, why is this effective in improving the glycemic response?
Yes, I talk about this all day long with probably every patient ever. So, pairing your protein with your carbs is going to slow down your digestion, so your blood sugar is going to rise slower. And that's kind of where I was talking about, like the mountaintops, getting those peaks, and instead you want the rolling hills. So when you pair carbs with protein, you're getting more of those rolling hills. Whenever you don't, and you have simple carbs, especially like sugar sweetened beverages, it's going straight up and straight back down, which can also cause reactive hypoglycemia, which is a whole other thing that we can get into another time. But so yeah, with that, you want to slow the digestion to slow the spike because protein, stimulates different levels of insulin secretion.
All right, I want to talk about a few, I guess, natural treatments, and these are things that are becoming more and more popular again on social media. So, berberine is often described as nature's metformin. So, I would love to hear what does the evidence show and what should we be telling our patients if they come in asking these questions?
Yeah. Supplements overall are a very hot topic, and they're also really hard for me to speak on with full knowledge because, one, there's not as much research on supplements because there's not the money backing them. And then there's not FDA monitoring of these things. Without underlying deficiency in things, there's not benefits to taking these extra things. Berberine has shown some good results in the studies, but those studies have some design flaws as well. So overall, if a patient asks me about berberine, I tell them I cannot recommend supplements because there's just not great evidence behind them, and there's not good regulation with the FDA as well.
Yeah. Now, another one I hear all the time is magnesium and that it can improve insulin sensitivity. What are your thoughts and what does the research show on that?
So if you're deficient, then yes. And same with, taking any sort of vitamin. If you're deficient in that, absolutely, it can improve your health. So if you have low magnesium and you replete your stores, then yeah, you're going to have improved insulin sensitivity. We know those two things go hand in hand. But if you're not deficient, it's not really going to improve things. And that's what the studies show. And that's, the stance that the ADA takes as well.
Yeah. I'm not anti-supplement at all. Actually, I think they're beneficial for certain patients. However, when I have a patient that comes in as they're taking like 8 different supplements, I'm like, you're throwing your money at something that is not necessarily proven. And why don't we just use that money and buy more fruits, buy more veggies, buy more lean protein, but really stock up your pantry and your fridge with these nutritious foods, and then you likely won't need these supplements.
One thing that I also tell patients, which I may have even heard it here too on your podcast before, but you can't out supplement your diet. So your diet matters the most. And then if we need to add other things in, absolutely. Like a multivitamin, sure. I take a multivitamin, not all the time, but sometimes. So yeah, I mean, absolutely. You can add in things if you really need them, but you've got to work on diet first.
Yeah. When I work with athletes, the athletic world pushes supplements like crazy. And you have a lot of FOMO if you're like, I'm not taking pre-workout and I'm not taking branched chain amino acids or creatine, right? You feel like you're missing out. But I remind them it is called a supplement for a reason. It is to supplement a well-balanced diet. So we have to optimize your diet first. And then if we have any deficiencies or any inadequacies, great time to supplement. So I like to take that thoughtful supplementation approach rather than just blanket supplement everybody.
Yeah, for sure.
All right. So you also treat diabetes with medication. And so a lot of patients now are opting for natural approaches over medication. So I would love to hear, how do you respond when a patient prefers, and only wants natural and they decline any medication for their diabetes?
So, and again, this is really individualized because one, I'll back it up a little bit. Prediabetes recognition and management matters. So if we can recognize that before it turns into diabetes, we have the chance to really buckle down on diet, lifestyle, exercise, all the things to help prevent development of diabetes. Once you develop diabetes, you're at risk for complications from diabetes. And my job is to help reduce that risk as much as possible and also in a timely manner so that, we're not sitting with an A1C of 13 for 6 months. Very dangerous. If a patient comes to me newly diagnosed with diabetes, they had no idea that they had diabetes until they ended up in the hospital with DKA, or they ended up, sent to the ER because their blood sugar on their labs was like 600. If I look at their A1C and it is over 9, that means we really do need to start some medication first. If they're against it, of course, all of my patients with type 2 diabetes, I'm going to sit there and I'm going to talk about their lifestyle. I'm going to go through a dietary recall. I'm going to talk about their activity level, things like that. But then I have to get into the conversation of, you are at risk for blindness. You're at risk for neuropathy that can lead to amputations. You're at risk for all of these things. And I want to help you reduce that risk. Unfortunately, we didn't catch it early enough to just work on diet and lifestyle. Now, if a patient comes to me with an A1C like 7.2 or something, yeah, for sure. If you want to start with diet and lifestyle modifications, let's do that. Let's buckle down, work really hard on that for 3 months, see you back, repeat that A1C and see the effect that it's made. Also with checking blood sugars in the interim for sure.
Yeah, I like that approach because you do have some patients who are like, nope, I got this. They put their head down and they really are committed to it, and it can work, and diet and lifestyle alone can be helpful. But I find as you're talking, I'm thinking about a similar approach in obesity management, and that is that the intensity of treatment has to match the severity of the disease, right? And it's exactly what you were just saying. For someone who's already got an A1C of 13, I mean, we've got to decrease their risk, and we've got to be way more intense with our treatment as opposed to, like you said, the person with an A1C of 7 definitely can give them the opportunity to just try diet and lifestyle. But that intensity treatment must match severity of the disease. I think that's a really good approach. All right, I know I want to talk about another hot topic and get your opinion on continuous glucose monitoring. So CGMs are all over the place on social media. I don't know why they became widely popular. I honestly think the glucose goddess and the fear of glucose spikes really triggered that. And everybody seems to be wearing a CGM. So talk to me about that and who could actually benefit from CGMs.
So I love CGMs in diabetes management. So anyone with prediabetes or diabetes could benefit from wearing one, even if it's just like the 2-week window that some of them are, like 10 days, 10 to 15 days now. If you wear that and you see how what you're eating affects your blood sugar, then you're going to change your food choices. I have several patients actually with prediabetes that have paid out of pocket to wear a sensor for a little bit, and it's helped reverse their prediabetes. They're no longer in that prediabetes range because they're wearing that and monitoring what they're eating. Patients with diabetes, I sit down and I go through the download of their sensor and show them like, hey, do you know what happened here? And sometimes it was yesterday that we can see like they had a really bad spike, and I'm like, what's going on here? What happened? Did you drink something? Did you drink a soda? Did you, eat candy, something different than, that meal that you had where you had chicken and vegetables and quinoa. So I can sit down and go through that with them. No, they're not always going to remember what they had 2 weeks ago that caused that, but we can see different things and they can see it in real time. We also, with endocrinology, don't love CGMs for just everyone because they're made for people with diabetes, and that's where the blood sugar number parameters are set to. So if the person who doesn't have diabetes wears a sensor, it's going to go off all night. The hypoglycemia starts at 70, less than 70 on the sensors. And a person with normal blood sugar, no diabetes, their blood sugar can be 55 or greater, and that's okay. So if you're wearing one, and we get a lot of referrals for like this person that came in and they were wearing a sensor and they have hypoglycemia. Yeah, it was in the 60s. That's okay. That's fine for a patient without diabetes. So
Yeah, I was thinking about that. I'm sure it's causing a lot of unnecessary fear and almost like creating like a what's wrong with me
mm,
kind of panic for people who don't have diabetes if they don't know how to interpret the numbers. So I think that's really where you come into play, a dietitian, but also maybe what I'm hearing you say is it might not be necessary or appropriate for somebody who's not even close to the prediabetes range. Is that right?
right. Yeah, absolutely. I don't think it's necessary at all. And they're expensive. Like, I'm pretty sure the over the counter ones are like $80 for a sensor or something like that. So, like, it's very expensive. Why not just, if you're wanting to know your body's blood sugar response, one, you could check a finger stick if you wanted to, but let's just watch what we're eating and not eat a bunch of simple carbohydrates that we know, like it's been studied, well researched, and proven that that's going to send your blood sugar straight up and straight down.
Hmm. Yeah, I agree with you. I can think of so many other ways to spend $80, but
Right.
um, another thing that I love about CGMs for patients with diabetes is it gives the patient objective information. We could tell the patient till we're blue in our face, hey, you really need to be pairing your carbohydrates with protein, right? We could tell them if you go for a 10-minute walk after dinner, your rise in glucose might be blunted. So it's not going to go up as high as if you were to just watch TV right after dinner. We could say that all the time and they might nod their head, okay, okay. But maybe until they see it, really reflecting and like, hey, Emily, I went for a walk and look at what happened, right? Do you see that happening? Do the patients have that aha moment when you review it with them?
Absolutely. Yeah, all the time. And like with the walking, like we know that walking after your largest meal of the day, that's going to help lower your blood sugar. And they can see their body's response in real time. And then they come in and they're like, you were right. And I'm like, yeah, I know.
Love that. I love that. I love when they tell us that we're right.
Yeah, yeah. And I think recently, like, I've had several patients that, were drinking a lot of sugary drinks when they came in. And, when you're told initially when you're diagnosed with diabetes, and let's say you went to primary care and they were like, primary care doesn't have enough time. Honestly,
Sure.
like
Uh-huh.
you just don't have enough time to get into the specifics of diabetes, but they're going to tell you like you need to stop drinking sugary drinks. Okay, cool. Then you come see me and all I have to address in that visit is diabetes. So we got time. And I am talking to you about, hey, how much Mountain Dew? I live in Kentucky. How much Mountain Dew are you having in a day? And they tell me 2 liters. And I'm like, hey, can we start working on cutting this down? Because that is a big deal, even if they're not completely cutting it out. Because if I tell someone after they're drinking 2 liters of Mountain Dew to stop it, that's going to be a very big goal for them that they just see as something that they can't do. And I have to meet them where they're at. So, would completely cutting that out be great? Absolutely. Is that realistic right now? Probably not. And then they get a CGM on. They see what happens when they drink that Mountain Dew and they're like, oh, yeah, I got to decrease that. They start decreasing it and then blood sugar significantly improves.
Yeah, I can't agree with you more. I love that approach so much. And it's easy when you're in primary care to just say, oh, cut out all sugar because you think that that's the best advice when ultimately, sure, we would love for them to get down to only drinking water. But you're right. To go from 2 liters of soda to only water, that's a very, very challenging ask. And I really don't know anybody who would be successful cold turkey doing that. And I love how you say like cut it back a little bit, like let's just knock it back a little bit. Can you go from like 2 liters to like 1 liter? I would love to hear what other things do you think primary care says that you're like, oh, it's helpful, but like not really?
I so a lot of patients come to me discouraged and they think I hear a lot, "Oh, you're gonna yell at me." I'm not gonna yell at you, that's not productive. That's not like, so if I come in and they were like, "Yeah, I was trying this visit, my A1C is 12, and you're gonna yell at me." I'm not. I'm not gonna yell at you, I'm gonna try to figure out, 1, are you taking your medicines? 2, how's diet and exercise? Has something caused you to not be able to exercise like you were previously and now your sugar's gone up? And then they'll tell me, "Well, my primary care doctor told me to cut out carbs." Or to stop eating fruit. Fruit, that
Oh,
I would say that's a big one, is not to eat fruit, and that kills me every time. You can have fruit. I do talk about, lower glycemic index fruits like berries. We love to see those. Higher glycemic index things like bananas and grapes. Limit to portion sizes, That doesn't mean you're having 3 bananas a day. I don't think anyone really needs 3 bananas a day. But yeah, so we have to make smarter choices with our fruits. Also try to pair that with a protein. So having some fruit and cheese, or I love recommending Greek yogurt and berries all day long. Like that is the perfect snack. You're getting protein in, you're getting fiber in, you're getting your antioxidants, like all the things. But they're scared of fruits when they come to me because primary care told them not to eat them, and to just cut out sugar, and they see fruits as sugar. So I would
yeah.
think that one is probably no carbs, cut your sugary drinks out, and then like limit your fruits. That one makes me sad.
It makes me mad. I'm so glad that you mentioned that because I don't know when this will die, this recommendation, but it drives me nuts. Like in what world do we think that fruits are bad for you, right? I mean, I think it became publicized because some major, major influencer said that grapes are like a sugar bomb and they're just as bad as a Hershey's bar. And it's like,
Mhm.
honestly, like a sixth grader would know that grapes are not the same as a Hershey's bar. Give me a break. So I'm really glad that you don't tell your patients to stop eating fruit because I'm definitely on team fruit. And 90% of Americans aren't getting enough fiber, and fruit is a really good source of fiber.
And
Plus,
fiber helps
anti
regulate blood sugars.
thank you, and anti-cancer properties. I mean, we could just list the benefits of fruit all day long. So if you're in primary care, please don't tell your patients to stop eating fruit. I think another big one I hear a lot is like don't have any white carbs, like white rice, white pasta. I love your thoughts on that.
So I do generally tell people try to limit things like potatoes, corn, white rice. But I mean, I don't go with the approach of completely eliminate anything. You can never have it again because that's going to make the patient want it more,
Yep.
and that's not helpful, especially to a patient whose family, let's say they eat potatoes with every meal or they eat rice with every meal, and now they can't share a meal with their family. That's difficult. So I also talk to them about portion sizes. But when they can, when they have control over their meal themselves, they need to try to choose whole grains. I love recommending quinoa. Not everyone loves it. So try even just something simple as changing from white rice to brown rice, whole grain bread instead of white bread, and then eating half or even a fourth of the potato. You can still have a little bit of it, but let's also, again, comes in pair with protein.
Yeah, we always coming back to that. It's my favorite strategy. So I love that. All right. I want to close with uplifting now. We've kind of bashed a little bit on our primary care clinicians, but we love you and you are doing a great job. Your job is so hard. I'm in primary care, so I know that. And we're all doing the best that we can with the time that we have. So we get it. However, let's give them something actionable. So we don't want them to say, all the things we just talked about. What kind of things would be really, really impactful from you as an endocrinology PA would you love to hear your patients told before they get to you?
I want primary care, if, with a new diagnosis of type 2 diabetes or worsening type 2 diabetes that they're sending to me, like ask them about what they're drinking. If they are drinking sugary drinks, don't just say, never have them again. Ask them how much they're having. See if they can cut that in half by the time they come to see me. And then that helps me because, of course, I'm going to ask them to cut that in half again. So
Right.
we continue to cut things in half and replace it with water. I want them to be drinking water. If it's, if they're not drinking bad things or they're already switched to diet, you can talk more about, eating more protein, pairing that with healthy complex carbs, and that, carbs are not the devil. So like we want to do fruits, vegetables, whole grains, those things are carbs and they're good for you. So don't demonize carbs, and meet them where they're at. Don't just give blanket statements of you need to do this or you need to lose weight. Let's try to change that into, hey, I think this would really help you.
Mhm. I love that. I think that's a wonderful approach and a great place to end. This has been such a fun conversation. There's so much more we could unpack. So if you guys want to have Emily back on for twinsy nutrition talk or more diving deeper into diabetes management, please send me a message on Instagram at Exam Room Nutrition. And Emily is also on Instagram. So what is your handle and where can people connect with you online?
At Twin Mama Med. So that's where I'm at on Instagram. I share lots of my kids' meals.
Yes, I love it. So if you're looking for kids' meals, doesn't just have to be for twins, but this is great for all toddlers. Go check out her page. I will link down to all of that in the show notes below. But Emily, thank you so much for the gift of your time and sharing your input as an endocrinology PA.
Yeah, thank you so much.
Thank you guys for carving out some time for nutrition today, and I will see you next week.